All right, everyone, so I think we're going to get started. Welcome to this RFS webinar. My name is Dan Sheilo. I'm the Chair of the Membership Council of the SIR Resident Fellows and Students section, or the RFS. For those of you who are joining us for the first time or unfamiliar with these webinars, the RFS hosts about 2 of them per month, and with the permission of the speaker, we actually record them and post them to our YouTube channel. So please do check it out if you're not familiar with it. We have a lot of great talks recorded, including non-clinical ones on device innovation, things like practice building as well. Our website is also a great resource for trainees. It's at rfs.sirweb.org. We have an FAQ on the new IR residency, which I know is of interest for med students, and we also have a lot of information for people applying to IR fellowship for residents and clinical materials. We have a case of the month, so please do check that out. I want to draw your attention to the chat box in the bottom right. If you have any questions, go ahead and type them into the box. If it says all entire audience, everyone will be able to see your question. And if you prefer, you can choose me, Dan Sheilo. I will be an SIR-RFS presenter, and then the question will only go to me. I will read out your question out loud so everybody knows what it is, but I've found in the past that some people prefer that. But either way, type in your questions, and we'll have Dr. Gonzalez answer them at the end. So having said all that, our topic for tonight is time, brain, and the interventional stroke treatment revolution. Dr. Gilberto Gonzalez has graciously agreed to talk on that topic tonight. Dr. Gonzalez did the majority of his training in my hometown of Boston, Massachusetts. He graduated from Harvard Medical School, did his residency at Brigham and Women's Hospital, and subsequently did his fellowship at Mass General Hospital, where he's currently the chief of neuroradiology. He also has a PhD in chemistry from UC Santa Cruz. So without further ado, I'll hand over the floor to you, Dr. Gonzalez.
Thank you very much, Dan. I thank you for inviting me. I'm delighted to be here tonight. Yes, I'm going to talk about the interventional stroke treatment revolution. It's quite an important time in medicine and in neurology, actually, in the neurosciences, because stroke is the biggest problem just by sheer numbers in the country and in most of the Western world. And having this huge advance that's now been established really positions us to help a lot of patients in a very significant way. Now, before I get started, I'd like to acknowledge a lot of people. We've been doing intervention for acute ischemic stroke at the MGH since the mid-90s. We've also been doing advanced imaging of these patients since about the same time. So both of these areas, both of these arms have developed side by side in a very interdisciplinary form. And there's 4 groups that have worked together, not just neuroradiology, but also the stroke service, which is neurology, the interventionalists that are now multidisciplinary, that involve people from radiology, neurosurgery, and neurology, and the Martino Center, which is our research center. And so these are just, I have a dozen names here, but thinking about it, there's been well over 100 people over the years, over the last 20 years, that have contributed directly to some of the things I'm going to talk about tonight and some of the insights that we've gained. Not everybody's still with us, of course. Some people were fellows and they've moved on. Some people, such as Greg Sorensen, who was at the Martino Center, is now the president of Siemens Medical in America. Walter Koroshetz, who used to head the stroke service when I started working with him, is now the director of the NINDS. So a lot of people have gone on to bigger and better things. So let me get started. This is what I'm going to discuss this evening. The bottom line is at the end there. What I really want to, what this whole talk is geared towards, is using the information that we've gleaned over the years, and most recently with the clinical trials, to go from all this experimental work and all these trials, clinical trials that have gone on before, to actually being able to treat individual patients in the fashion and in the best possible way. In other words, be able to evaluate the individual patient and decide to treat or not treat, depending on that individual's specific circumstance. So that's the whole goal. So I'm going to start off painting the big picture of the problem, which is a subset of ischemic stroke, what people call LVOs, or large vessel occlusions. I'll then discuss what's happened in the last couple of years, what I call the interventional revolution, with the new devices that have come online. And then I'll spend a considerable amount of time talking about time and infarct growth. This is a very complex subject, very complex topic, And understanding it is what's going to lead you as an individual practitioner to make the wisest decision for individual patients, which is the last part of my presentation. So let me just lay out the problem. This is a cartoon that I've used for many years. This is a person who's had an embolus that lodged in the right middle cerebral artery. And that embolus causes a reduced blood flow distal to it. And because of that, part of the brain dies rather quickly after that. And that's known as the core. There's also another area that we call the penumbra that's underperfused and may be symptomatic, but it's still alive. And if you can recover flow, that area will come back and be totally normal. So that's the idea of intervention, is recanalization, thrombectomy. So with time, if you don't do anything, the core, the infarct core or the ischemic core will grow, and that, of course, is bad. Now, the most important physiological principle that I'm going to discuss tonight is this one right here. The rate of growth of the core, the ischemic core, is highly variable. It's far more variable than I ever imagined when I started doing this work 20 years ago. And it's entirely a function of the strength of the collateral flow. And the collateral flow is quite variable. That's basically it. So in a particular period of time, it might be early for one patient, and in the same period of time, it may be too late for another person. That's the key concept. Okay, this is a middle cerebral artery occlusion. This, as well as terminal ICA occlusions and basilar arteries, are known collectively now as large vessel occlusions. The vast majority of them are in the anterior circulation. So that's when people talk about LVOs, this is primarily what they're talking about. And the MCA is the largest proportion of those. So these LVOs, these large vessel occlusion ischemic strokes, account for about a third of all strokes. However, they're the bad ones. They account for 90% of deaths that occur during hospitalization for stroke, and they account for well over 50% of the severe disability, as well as the vast majority of costs associated with dealing with stroke, both direct medical, but also rehab, and then costs to families and society. It's a very, very big burden. So if you're able to treat this disease, this part of the disease of ischemic stroke, you are in fact treating a large part of the global problem in ischemic stroke. Now, if you don't treat patients that come in with an LVO, they don't do very well. If people come in with severe neurological deficits with an NIH stroke scale of 10 or greater, and they have one of these large artery occlusions, and you do not treat them, less than 1 in 5 will do well spontaneously. TPA does work. It does work in a good number of people. If you can give TPA, and this is our own data that we collected at the MGH in San Francisco, UC San Francisco. If you give it within 3 hours, about 35% of patients with this condition will have a favorable outcome. That is, what we call favorable is they can live independently. They may not be entirely perfectly normal, but they can live independently, and that's the gold standard for favorable outcome. So that's what you can do with TPA. Of course, that means still that you have 2/3 of patients that, even with TPA, if they show up, with 3 hours you can give them TPA, you only get 1/3 of the patients. The other 2/3 are still doing poorly. And of course, the vast majority of patients come outside the TPA window. So there's a large number of people that don't have the opportunity, aren't going to do well. Okay, so let's go back to my cartoon here that shows the core, the penumbra, and what links the two is the collateral flow. So what you want to do is treat before the core gets too big, okay? And I've already mentioned TPA, but the other one, and the more effective one, is thrombectomy using the modern endovascular tools. And you want to do that, though, before the core, the infarct, gets too big, because if you wait until the infarct gets too big, then you'll have the danger of causing a hemorrhage or malignant edema, and actually making an already bad situation even worse. So that's what you have to deal with. You want to treat somebody before it's too late. The therapeutic window in terms of the core is actually quite narrow, and I'll show you some data about that. So how do you measure the core? What biomarkers that we have? Well, the traditional one has been time. Okay, time is brain. Everyone's heard that. And so the sooner you can do it, the better. And that is true. There's no question about it. The sooner the better. But sometimes time is not the most optimal biomarker, and that's where imaging comes in. And imaging has been proven in the last few clinical trials to be an important partner in helping decide who to treat and who not to treat, who to select for endovascular therapy. I want to talk about the importance of the infarct volume. This is a paper we published a couple of years ago in Stroke. The title of it is that infarct volume is the best biomarker for outcome after endovascular treatment. This is a study of over 100 patients in whom all of whom had a large vessel occlusion and all of whom had endovascular therapy. Now, this is using old technology, not the new stent retriever technology, but still it provided valuable information. And what we did was we looked at a large number of variables, but the most important variable turned out to be the size of the infarct after you did the procedure. If the infarct was small after the procedure, patients did really well. If it was big, they didn't do so well. And the data from that paper is shown right here. It's a histogram, and each histogram shows the number of patients that had a poor outcome, that's red, and the number of patients that had a good outcome, which is in blue. And they're binned by volume. So 0 to 30 milliliters is the first bar, 31 to 60 is the second bar, and so on and so forth. And just looking at it, you can see what a fast drop-off there is in the favorable outcome rate that you see in terms of final infarct volume. And that's why I'm saying that we have a very narrow therapeutic window. This is the same data. I just put it in tabular form and I've grouped them a little bit different. But it shows the same thing. It's the same data. So if your infarct volume after treatment is less than 60, the good outcome rate is nearly 50%. And this is using old technology. So this is really an outstanding outcome. If the final infarct volume is somewhere between 60 and 120 milliliters, only 1 in 4 did well. And if the volumes are greater than 120, nobody did well. Nobody, 100% did poorly. So this is final infarct volume. So before you actually try to do therapy, you want to get below these levels, right? And so we've picked 70 milliliters as the optimal or the maximum volume that we want to see by imaging before we do the procedure, because we expect there's going to be some growth. And so we want to stay under 70. If people have less than 70 milliliters of ischemic brain, then the probability of a good outcome is actually quite good. Once you get above 70 milliliters, it goes down. It's not that we won't do the treatment, but the probability of a good outcome goes down. So that's why this is also important. It's a critical factor, and the therapeutic window is quite narrow. So let's talk about the revolution, which is really upon us. It came very fast and very furious, and it really will help many, many patients in the future. This is the first trial that was published, a randomized trial of intraarterial treatment for acute ischemic stroke. This is the Mr. Clean trial that was announced last fall and published the 1st of January. And this was followed by 4 additional trials. They're all listed right here. So there was Mr. Clean, Escape, Extend IA, Swift Prime, and Revascat, all of which have now been published in the New England Journal of Medicine. All of them showed the same thing. It showed that thrombectomy using these new stent retrievers or stent retrievers clearly produces clinical benefit in patients. And actually the data showed that they showed this in relatively small numbers of patients. So it's a very potent treatment. And this is what made it possible. The single most important thing is this advance that we have had in devices. And these are the stent retrievers that Leslie Mosley, this picture was lent to me by Bay, that shows a couple of the stent retrievers that are out there that have been FDA approved. And these have revolutionized the field. Before, we were lucky to get 50% recanalization rates. Now people are reporting 80 to 90% recanalization rates in major artery occlusions, which is phenomenal. If you can do that, then the only thing you need to do is be able to get up there and make sure that there already isn't a big infarct. So that's number one. But there was a couple of other things that also were very important. Oh, this is just a couple of examples of how effective these stent retrievers are. These are two different patients. One had a terminal ICA occlusion. That's the patient on the left. Another one had an M1 occlusion, the patient on the right. And this is for each of them a few minutes later after the stent retriever was deployed and the thrombus was pulled out. And you can see the excellent anterograde flow in these people. So the stent retrievers was the big advance forward. But there was also something else that differentiated these very successful clinical trials from prior trials such as IMS3 and other trials that were tried and really were not successful. And that was the use of more advanced imaging modalities to select patients. So these were selective trials. Not before with IMS3, for example, time was the main parameter. So if you fit the time window, you got treated regardless. I mean, you did get a non-contrast CT, but most of the people early on, non-contrast CT is not that informative. So all of these trials here all use CTA, or in the case of Avascat, they also used MRA to identify a target lesion. Okay, that seems really simple, but that was not done for a decade before these trials. Also, most of these trials, Escape, Extend IA, and Swift Prime use additional advanced imaging to select patients, basically selecting patients that had small core infarcts. Escape used good collateral circulation using a CTA technique, and Swift Prime and Extend IA used perfusion imaging to select those patients. Now, we do things a little bit differently at Mass General, partly because we had more experience than everybody else, and we've developed our own approach to selecting patients. And we conducted, basically simultaneously with these clinical trials, we conducted a prospective observational study that we just submitted, and actually it's already come back from review, and we've asked for some minor revisions, and it's about to be published. Anyway, it's based on our algorithm that I'm going to speak about right here shortly. As I said, we started using advanced imaging some 20 years ago, and we used to do basically everything on everyone. So that would be, if we could, we'd do CT, CTA, CT perfusion, diffusion, perfusion imaging on as many people as possible. And the reason we did it was we thought that all these various parameters would give us additional information that would help us properly manage the patient. Well, after about 15 years of doing this, we went back and looked at our data, and we found that some things were valuable and some things were not. All the techniques are good for hemorrhage, artery occlusion, and late infarcts. However, for identifying in a precise manner, in a manner that's valuable to make critical decisions, the early infarct core, the only really reliable method we found was diffusion MRI, DWI. It provides a measurement that's reliable and has sufficient precision to make decisions in individual patients. The other major finding that sort of surprised us when we adopted was that there are multiple ways of measuring the penumbra, and you don't have to be precise. It's the opposite of the core. With the penumbra, all you need to know is that it's large and it's causing a significant deficit. So just the clinical examination of the United Stroke Scale is enough to tell you that there's a large area at risk if you don't do anything, and that's sufficient information to go ahead and proceed with the therapy. So this is our algorithm. This is how we evaluate a typical person that comes in, someone with a new neurological deficit. Typically, they go straight to the CT scanner to rule out a hemorrhage or an already established large infarct. Then they all get CTA, and here's where we look for a target lesion, a treatable lesion, proximal occlusion, an MCA or distal ICA occlusion. And if it's present and there's no infarct, those patients are, if they're otherwise eligible for endovascular therapy, they'll be taken quickly to the MR scanner, and basically the only thing we really need there is a diffusion study. It takes a couple of minutes. It's very, very fast. And if the lesion is less than 70 milliliters, and we calculated on the screen as the data comes up by the A by B by C method divided by 2 method, which is very simple. If it's less than 70 milliliters, it's a go, and the patient is classified as likely to benefit. So these are the people that do best. These are the ones that we expect to have good outcomes. There's a couple of other parameters that need to be, or a couple of other variables that are also important for a patient to be classified as likely to benefit. The most important is age. They should be less than 80. And the other one is time since the start of the infarct. It's got to be 6 hours. That's historical. It may not last much longer. But those are the major points for classifying either likely to benefit, uncertain to benefit, and then there's the final group is people that we don't think will benefit and we don't recommend therapy, are people that have already a diffusion lesion of greater than 100 milliliters. Okay, here are results shown in this table, which I've listed along with the results of the 5 trials that I mentioned before. Like I said, this is a prospective observational study, and so we treated a lot of patients, this is one center, and we classified them into 3 groups: likely to benefit, uncertain to benefit, and then of course there was a subset of group people that couldn't get MRI, so they got CT, and we did the best we could. Now this study started before we were using stent retrievers on a regular basis, so only 70% of the patients actually were treated with the modern technology. Nevertheless, the people in our study that that were classified as likely to benefit had a good clinical outcome, so they were living independently, and that compares favorably with all the other trials. It's better than Mr. Clean or Vervascat, but lower than Extend IA and lower than Swift Prime. People that were uncertain to benefit, this is expected, it didn't do as well. Only 1 in 4 did as well. And people that couldn't get DWI, we were sort of guessing, only 29% did well. The big difference, though, well, this is comparable, even though we use fewer stent retrievers. The big difference is the proportions of the people that we treated. 1 in 3 that we evaluated, that's 1 in 3 of patients that had a large vessel occlusion that potentially could have been treated, actually got treated. That compares to 1 in 14 for Extend IA and 1 in 7.5 in Swift Prime. And I'll come back to this. We don't know the screen versus treated numbers in the other trials. I'll get back to that. Okay, so that's the interventional revolution. Now I want to focus on time and infarct growth. Most people think it's a fairly simple concept, time and the infarct's going to grow and that's that. But it's actually much more complicated than that, and this bears directly on optimizing treatment in individual patients. So this is one of the most famous papers in the stroke literature. The title of it is "Time is Brain Quantified." This came out 9 years ago, and the most famous quote in all of stroke is in the abstract here, and it is that the typical patient loses 1.9 million neurons each minute of which stroke is not treated. So time is brain. You've got to treat it. Every minute that you waste, you're losing almost 2 million neurons, and it's the driving force with much of what we do. And it's true. People do lose brains. They lose neurons if you're not fast in trying to cure these people. So let's think about it a little bit more. I created this hypothetical graph. This hypothetical graph, assuming that someone is losing a certain amount of neurons every minute and so many neurons per hour. Now this graph here, this is hypothetical graph here. Each circle represents an individual patient, and it shows the size of the infarct versus the time after the stroke onset. And so these are, I don't know, 40 or 50 patients I have right here. And the size of the infarct is in the vertical axis and time is in the horizontal axis in hours. And we would expect if everyone's strokes grew more or less the same, you would expect if you graph this data that it would form more or less a correlation like this, sort of linear. There would be some scatter, some variability, but basically the longer you wait, the larger the infarct would be. And this would also explain a well-established phenomenon shown not only with IVTPA, but also in the endovascular trials, even IMS3 that failed. All these trials have shown that the earlier you treat, the more likely you're going to have a good outcome, the higher the probability. And the longer you wait, the lower the probability that you have of having a good outcome. So that concept of infarct growth with time is actually is supported by these data that have been published over many, many years. However, it's not entirely clear-cut, and this first came to our attention when Bill Copen and our group started looking at patients out to 24 hours who had diffusion-perfusion imaging. And he found that a large proportion, in fact over half, still had a large diffusion-perfusion mismatch even up to 24 hours. And so we started to look at this a little closer, and we were quite surprised at what we found. Here, I'm going to show you in these next couple of minutes a series of images, one right after the other, of I think it's 19 patients. These come from Bill Copen's study. All of these patients had MCA occlusions, M1 occlusions, proximal MCA occlusions, and all of them we knew or had a very good estimate of when the time of stroke onset began. So this first patient had a stroke onset 1.4 hours after, was imaged 1.4 hours after stroke onset. And we really don't see very much. But let me just run this little scheme. So there's a different patient at 2 hours has a very large infarct. This patient at 2.4 hours, small infarct. 2.8 hours, large infarct. 3.4 hours, I don't see the infarct. 4.4 hours, small infarct. 4.5 hours, small infarct. 5 hours, very big infarct. 5.3 hours, small infarct. 5.9 hours, medium. 6.4, large. 6.5 hour patient, small. 6.6 hour patient, large. 6.8 hours, small. 8.2 hours, pretty small. 10 hours, small. 16.8 hours, small. And there's the last patient, 21 hours, moderate size. So you get the picture here. It's really pretty random. It doesn't, it doesn't matter. So this is really quite striking to us. It really flies in the face of everything we believed. And so we did a prospective component, and we looked at a series of patients. We looked at 186 patients who came into our emergency room, got scanned by MRI, had DWI, near the time of stroke onset. And we plotted it and plotted that data. We published this a year ago. And here's the data. And so each circle here on this graph represents one patient. The vertical component here, it tells you the size of the diffusion lesion, so it goes up to 350 milliliters. And then the horizontal axis is in hours. It goes up to 24 hours. And you can see here that there's a total scattergram. There's absolutely no relationship between the size of the infarct and the time from stroke onset. The R squared is 0.006. There's no relationship. It's totally independent of time. Now, these included terminal ICAs, proximal M1s, and but when we did subset analyses of just M1s or just terminal, we got the same scatter plot. No relationship between them. Now, I put the 70 milliliter line here because that's our favorable, likely to do well category. Now, the interesting thing is that the majority of patients, regardless of what time they come in, the majority of patients have an incipient infarct or core infarct that's less than 70 milliliters. So all these people are eligible. But you don't want to treat these people over here. And some people come in really early with already a big infarct. So you want to avoid those. So that's the challenge. This is the we picked every, I think it's every 13th or every 14th patient, and we just, from this study here, this now is a prospective study, and we is laying out here every 14th, the first patient and then every 14th patient. And you can see the first patient was at 1.2 hours, small, but then the 1.8 hour patient is large. The 10.9 hour, one of the later ones, is a small infarct. So it's really a totally stochastic process. It's totally random. Just looking at a patient, and then just looking at the occlusion on the CTA does not tell you how big the infarct is. Every patient is different. And why are they different? The reason they're different is that each patient has their own collateral system, and it's highly variable. This person here has a really good collaterals. This person has terrible collaterals. And so they have much different size infarcts, even though the times are very similar. Now, when we first submitted this, we said that the best way to explain this was the collateral circulation. It was rejected, saying and one of the reviewers said that we were just speculating, and so we couldn't justify our claim. Well, we went back and we looked at our data, and it turned out that this was the time when we were doing, the data was collected in an era when we were doing perfusion on everybody. And we had perfusion data on over 2/3 of the patients. And it actually supported our conclusion. And this is an example of some of the patients. These are two patients that came in roughly, were imaged about 6 hours after the stroke onset. And both of them had M1 occlusions right there and right there, but otherwise they're very different. We don't see collaterals at all. Just as the patient on top, we see very good collaterals in patients on the bottom. This patient has a very small diffusion abnormality. This patient has a large diffusion abnormality. And you can see the differences in perfusion. The cerebral blood flow is very good in this patient with good collaterals, and therefore that's why the diffusion lesion is small, whereas the collaterals is poor on the patient on top. The cerebral blood flow is poor, and therefore you have a big infarct. So the DWI, the size of the infarct that you see, or the core that you see with DWI, tells you in a very quantitative and direct method the quality of the collateral circulation. So it's a very powerful and very precise measure. So that's infarct growth. It's very clear. There's no question about it. Everybody's different. Just by looking at the patient, just by doing a clinical examination, just by looking at the CTA, you don't know how big the infarct is. You don't know if you're too early or if you're early enough or too late. The other part of this whole time and brain issue is how the infarct grows. And the reason why this is important, well, it does have important implications. I used to think that the growth was linear, and that's what my hypothetical graph showed. But if you look at the animal literature, it's not linear. This is a DWI growth in an animal model, a bunch of animals, and it shows in all animal models that the growth of the diffusion abnormality is actually logarithmic. It's not linear. Now they were measuring, these guys, they were measuring every 10 minutes or every 15 minutes out to a couple of 3 hours. In humans, we can't do that. In fact, there's very little data. Until recently, we collected data where we, in a series of patients in which we imaged people multiple times over a relatively short period of time. This is a study that was NIH funded. It was run by my good colleague and friend, Anish Singhal. And in this study, we got a series of imaging studies at baseline, which was usually 4 hours after stroke onset, at 12 hours, 24 hours, and 48 hours after ictus. There was something over 80 patients in the whole study, but 38 of them had LVOs. They had proven occlusions of the MCA or the distal ICA when we first imaged these people. And so these are particularly interesting of interest to us right here, because these are the people that we can try to help using endovascular methods. So what I did with these 38 people is I grouped them according to the baseline diffusion abnormality. That is how big the diffusion abnormality was when they first arrived. Most of them, 23 of them, had diffusion abnormalities of less than 50 milliliters. 6 had baseline diffusion of between 50 and 100, and 9 had a diffusion abnormality greater than 100 milliliters. And what I did here is I extrapolated back to 0. And just looking at this graph, you can see the similarity with animal models. In fact, this looks very similar to animal models. And if you fit graphs, logarithmic graphs, you actually get very good logarithmic fits. And the R-squares for this are on the order of 0.98. Very, very highly correlated with logarithmic growth. So what we see in humans are logarithmic growth in infarcts. And this has actually a practical ramifications, as I will talk about in a second. So let me just go back to our data set here of all 186 patients who came in between 0 and 24 hours after stroke onset. And you can see that it's totally random. Now, you have to understand that each measurement is a snapshot in time, but you have to think in terms of the dynamics of what's happening in the patient. If you think about that, then you need to you come to the realization is, although it's a point in time, it traveled back to the origin in a logarithmic fashion. So I'm putting up 10 lines actually to sort of describe the general pattern of logarithmic growth that we see in patients that show up. So the patient over here that I'm pointing at, it's after 16 hours. He's got a small infarct, but it started at 0 and grew very, very slow. The patient over here at 2 hours is already at 150 milliliters. He's growing very, very fast, and that's when we took the snapshot. But these are fast progressors and these are slow progressors. And this is very important. What you really want to do is catch people that are slow progressors. The fast progressors you could probably only harm. Okay, I took away all the dots and I left the lines to make a point here. You can see this red square that I've put superimposed here at less than 3 hours. If you treat people less than 3 hours, you can see that the majority of the patients are going to be under the 70 milliliter line. So the probability of good outcome is going to be really, really good here because all these people are likely to have good outcomes. And that explains this graph here. Now, I've said before that if there was linear growth, you would expect to have a higher probability of good outcomes if you treated them early. Well, if you have logarithmic growth, you have the same phenomenon. The earlier you treat, the better. However, the implication of this logarithmic growth comes in the later time points. It doesn't really matter whether it's logarithmic or linear. Out here, though, in the endovascular time window, it does matter because at this point here, you're in the flatter part of the curve. And because you're in the flatter part of the curve, your growth is slow. That means you have time to make a proper measurement before you decide to treat this person if he's here or not treat this person if he's out there. So the endovascular area in here is a time where you actually have time. People that are likely to do well are actually at the flat part of the curve, and you have time to make a proper measurement. So this is the TPA window to 4.5 hours. I think that time is probably the best measure in this time because you've got the fast progressors in here. If you're going to get them at all, you have to treat them right away. However, once you get into the 4 to 8 hour time frame, the endovascular window, you've got fast progressors and slow progressors. You have enough time because of the logarithmic growth phenomenon to actually take time to see whether your patient is here or here. Because this patient you may actually hurt, the patient down here you're likely to help. But moreover, this data shows us that really the endovascular window probably extends much greater than 8 hours. Really, it probably goes out to 24 hours, best I can tell. If you find a patient with occlusion that you can treat and his incipient infarct, the core infarct is still small, then you have a great opportunity to help these people. And you have the time because these will be slow progressors and you have the time to figure out how big their infarct is. Okay, with that as a background, now I want to get to the crux of the matter here. It won't be very long, but I think that the most important thing that we need to do is figure out how we can take all these wonderful advances in technology and the results of the clinical trials and actually apply it to individual patients. So how do we go from clinic to an individual decision? So the question basically is you have a patient who comes in and you have an occlusion and it's 4 or 5 hours out. That's typical for someone like this. It could be 7 or 8 hours. The question is, do we want to intervene on this patient? We go with thrombectomy. I already said that we have 2 biomarkers, but after the 4-hour window, because you're the flat part of the logarithmic core, time is no longer a reliable biomarker, so you must use imaging. The last question is then, how do you image these patients to reliably differentiate people between those that you will treat and those that you won't? I've already told you that we use DWI, and there's a good reason why. We've looked at the data. Now, I want to go back to the study we did that showed that infarct volume at the end is the pivotal parameter, and I showed you that there was a very narrow therapeutic window in terms of infarct size and whether or not they're going to do well or not. So you want to be below around 70 milliliters before you treat in order to get a good outcome. So here's the same table I showed you before. Now the question is, how precise does your measurement have to be? How accurate must your core measurement be? Would 10 milliliters cut it? And I think 10 milliliters is actually a pretty good number. In fact, that's the precision of diffusion measurements. They're plus or minus around 10 milliliters. And that allows you to do the best, I think, in terms of selecting patients. What about 50 milliliters? I think this is way too big. And looking at our data, it appears that using CT perfusion to try to estimate the core, that's the range of error that you get. I don't have time to tell you why it's so bad, but there's several theoretical reasons, and there's also practical reasons. There's basic physics. It's a poor signal-to-noise method, and so you're going to have a poor measurement. Now, I know many of you have read the studies, such as Extend IA, and you'll say, well, they use CTP, and they got good results. The answer is yes, they did, but the way they did that was they used a threshold to select for patients that had very, very small cores. So if you have a core infarct of 10 milliliters, even if your error is 100%, you're well below the 70 milliliter threshold. But you pay a price for that. If you do it, if you use that strategy, you're going to exclude a lot of patients. In fact, that's what happened. Here's Extend IA. They screened well over 1,000 patients in order to select 70, okay? So they excluded a lot of patients that could have done well. Same thing with Swift Prime. They screened several hundred to select, they screened over 750, around 750, to select 98 patients for evaluation. So that's the price you pay with a less precise method. And that's why with us, with high precision, we were able to treat patients. We were able to select 1 out of every 3 patients that we treated. And how does this all work out? Well, if you work out the numbers, if you're able to treat more patients, the more patients that you're able to treat that are below that particular threshold, the more additional good outcomes that you will get. And this is a calculation that I did based on the data in the Extend IA trial, the Swift Prime data, and then our MGH data. And we had 12 additional good outcomes for every 100 patients that we evaluated, which was 2.5 times greater than Extend IA and 50% higher than Swift Prime. And this is using only 70% of the time stent treaters. All of these guys used it 100%. So with 100% stent treaters, this would be an even better comparison. So that basically sums what I want to say. These are my basic conclusions here, that infarct growth is logarithmic. You have to understand that, and infarct growth is very, very variable. And for the very earliest time points, if somebody shows up at 2 hours, even for TPA or even for endovascular, time really is the best biomarker at that early time point. However, once you get out to past 4 hours, which is really the principal endovascular therapy time window, then you really need a way of measuring the core infarct, and diffusion is the only method right now that has sufficient precision to be able to optimally select patients for therapy. So that's my presentation for this afternoon. I've talked about the problem, which is large vessel occlusions that accounts for only a third of all strokes, but is responsible for the vast majority of the poor outcomes and deaths. I've discussed the interventional revolution, which is basically the use of the implementation of modern thrombectomy methods that are very effective. I spent quite a lot of time talking about the complexity of time and infarct. Every patient is different, and it really, really is important to understand, to try to understand the differences or the unique physiology of that individual patient to make the right decision and to go from these wonderful positive results in clinical trials to excellent results in individual patients. Thank you very much for your attention. And I'm happy to take any questions.
All right. Thank you so much, Dr. Gonzalez. Awesome talk. If anybody has any questions, please type them into the box. I haven't gotten any personally into my own username, so if you've been trying to send it to me individually, you sent it to the wrong person. Dr. Gonzalez, I actually had a few questions of my own. As you're talking about the importance of collateral circulation and how that individualizes for time, I was wondering, do you envision a future in which you can do a CT-CTA and have an imaging modality smart enough to look at your collaterals and look at where your actual clot is and the size of it and say, all right, this is going to be your time curve for your person, for your patient, and I'm being told that this patient is 3 hours in, so with blah, blah, blah confidence interval, I can say their core is probably going to be, 30, 50, 80, especially for the patient that's maybe 7 to 10 hours out. Do you envision something like that being calculated?
No, I think we have the method. I think that I haven't showed you all our data, but the best predictor of outcome is actually the rate of growth based on the diffusion measurement. So if someone comes in with a 50 milliliter core and he's 2 hours out, that means his infarct has been growing at 25 milliliters per hour. Looking at our data, all our data, nobody that's growing at a rate of 70 milliliters per hour or greater has had a good outcome. So that's an absolute number. So if someone comes in at 5 hours and it's only 60 milliliters, that's 12 milliliters per hour. You still have time. You have an hour or two before it gets up to 70. So I think, yes, I think that the answer will be MR. I think that once people figure out that you're not treating people that could be treated, or you are treating people who should be treating, and that we are dealing in the time domain where the logarithmic curve is flat, there is time to go to MR, and the vendors are going to just give you a push button answer of how big the DWI lesion is, and then you just divide by time, and you'll have a rate, and that's it. That'll give you the best indicator of whether or not you should go in or not. So yes, but I think it's going to be, because you need precision. Collaterals, good, bad, yeah. I think collaterals, they work, but again, they work if they're great collaterals, but if they're intermediate collaterals, it doesn't work anymore. Perfusion works, CBF, certain thresholds, it works if you have a small core infarct, but it doesn't work if it's intermediate. Let's say it's 50 milliliters. So that's the problem. For the easy ones, both of these methods work. But for the challenging ones, which is, a good proportion, going up at 30, 40, 50 milliliter core infarcts, they just don't have the precision. You have to go to MR to get that precision.
Mm-hmm. All right, so we have a couple of questions from the audience. If a patient can't get diffusion imaging, maybe can't go on the MRI, well, what is your number two? Do you go to CTP at that point? And also,
yeah, about a third don't. Yeah, some people don't, and I showed you the data on our results for CT only. Maybe I'll just go back to that just to show it. Yeah. can't get it off. Anyway, this is the results here. You see, this is, there was 102 patients, 103 patients, 31 couldn't get MR for one reason or another. In the old days, we used to do CT perfusion, and nowadays, we realize that, in fact, it's just too unreliable. And so we just dropped it altogether because sometimes we were treating people that we should have treated. So basically what we use here is we use the standard time. If there's good collaterals, then we'll go for it. And then we use the aspects score. So that's the best we can do. But of course, we realize that our results aren't going to be as good. You know, they're going to be in the area. It'll be like Mr. Clean. Mr. Clean is all you need is an occlusion in less than 6 hours and no obvious hemorrhage, no obvious infarct. And you're going to get 33% good outcome rate. Okay, so that's good. That's as good as you're going to do with CT. CTA, I mean, with CTP, you can get really good rates, but then you're only treating 1 out of 14 patients. The collateral score, they didn't tell us how many patients, but they'll let you know if there's people that they probably could have done well, but they couldn't treat them because they didn't have this excellent collateral score where they see collaterals come all the way back. So I mean, that's just the way it is. So yeah, sometimes you can't, and so you just do the best you can with what you have. We have the capability for CT perfusion, but the data is overwhelming that it's random, and any one individual, you can be totally wrong, and you just don't know. It could be spot on. It could erroneously tell you that the infarct is 50 milliliters too large, or it can erroneously tell you that the infarct is 50 milliliters too smaller than it really is. It's really a random shot. So we feel that just CTA is sufficient to make the decisions, realizing that we're just not going to do as well, but we're stuck with it.
Sure. And in terms of a practical thing, how do you measure infarct volume if you have like an incredibly irregular shape into consideration?
Yeah, well, most of them it's actually not that hard. Probably 80% is fairly straightforward. It's just you find the slice that has the largest diffusion abnormality. You measure in 2 dimensions, A times B. Then you count the number of slices that you see the diffusion abnormality. So that's C, A times B times C divided by 2, and that's accurate to 10%. That's as accurate as you need to be. Now, if it's scattered all over the place, that's actually a little unusual. If they're big blobs, then you could do the same thing in different sites, but that's pretty unusual. A bunch of scattered little ones, you can try to do something like aspects to do that, but usually if it's scattered small, if you have an MCA and you have just little dots everywhere, you've got a small infarct, you know? So yeah, we don't know the precise volume, but it's small. So at that point, it's more qualitative, but it's a go usually.
Sure. And in terms of favorability outcomes and follow-ups, how often do you get follow-up, subsequent imaging, and in terms of ranking them? I think the question is referring to maybe modified Rankin or NIH stroke scale. Yeah. How do you measure a lot of the outcomes?
Yeah, our principal outcome measure is modified Rankin scale at 3 months. So this list right here that I have on the screen right here, these are all people that had they lived independently. So it's modified Rankin scale of 0, 1, or 2 at 3 months. That's our principal measurement. We also measure MRS of death is an MRS of 6, so that falls into this as well. So that's how we do it. We have our service is very, very careful to follow up on all these patients. Everyone that gets treated endovascularly will get followed up, and someone will call them or call the family members to see how they did at 3 months.
Okay, great. And what is your approach specifically with anterior versus posterior circulation at MGH? Has that changed recently based on the data, although most of it's anterior?
Yeah, most of it's anterior. The posterior, and this has not changed at all. in the whole 20 years we've been doing this. I mean, one of the first, in those early days, it was urokinase was available. It wasn't bad, actually. Things went bad when they took urokinase off the market. But anyway, one of our I think the most dramatic case we ever had, or that we had in the early days, was this cook who was on a boat, on a merchant cruiser, and was unconscious for 24 hours before they arrived in port in Boston. And they brought us to the emergency room, and he had an occlusion. He was unconscious, and he was going to die. And so we did the procedure, opened it up with urokinase, and he woke up. And the guy did fine, and it was
Wow.
22 hours afterwards. So that taught us early that with posterior circulation, it's a different beast. You're dealing with the brainstem. There really isn't a good volume measurement, and there's the collateral circulation in the posterior fossa is very, very strange. And you can have a complete occlusion of the basilar and look like somebody who's near death, but actually a good portion of the cerebellum and the brainstem is still alive, even though it's dysfunctional because of hypoperfusion. And if you can open it up, we'll do it. So basically, we'll treat anybody that doesn't look, well, not anybody, but we'll treat a lot of people. There's less concern about time with those patients, and there's less concern about a specific volume of diffusion. And so it's a different beast altogether. Thankfully, it's less than 10% of them, but it's a totally different beast, and you can't translate anything that I've talked about tonight to the posterior fossa basilar artery occlusions.
Sure. And in terms of complication rates, specifically hemorrhage, what's been your experience at MGH with people getting more experience, the newer stent retrievers? What's your been experience with that?
Yeah, they've been going down, so it's well under 20% now. The mechanical devices, it's actually this is an interesting story that's developing. I think that one of the directions that we may be heading is avoiding TPA altogether. Some of the data that's coming out is that the hemorrhage rates the hemorrhages that we do see are usually in patients that got TPA first and then got mechanical recanalization second. So when they got the recanalization, there's already TPA on board, or there's already cascades flying along. So our hemorrhage rate is under 20% overall, but I think there's something that we're still looking at. There may be a relationship between thrombolytic use in combination with mechanical use that might be not so good, and there might be a good argument to just skip the TPA altogether. I know some groups in Spain are doing that. They just go straight. They see an occlusion. They get the CTA. If there's occlusion, they say TPA only slows you down. They just go straight to the edges suite. So I think that the hemorrhage rates are good. They're getting better, and I think they may get even better yet.
Okay, and another question here is about specifically just the penumbra size, independent of core penumbra or ratios. How much emphasis or how much interpretation goes to just penumbra on the imaging itself? Okay,
so when you have an occlusion of the middle cerebral artery, an LV or the terminal ICA, if you have a diffusion lesion of less than 70 milliliters, 100% of those patients, so you have an MCA and an MCA occlusion and a lesion of 70 milliliters or less, 100% of those patients are going to have a mismatch of at least 100%. I mean, think about it. If you're occluding the MCA, you're putting at risk 300 milliliters of tissue, 250 milliliters of tissue, at least. So that's the penumbra. You don't have to measure that for me to tell you got a big mismatch. Okay? Rarely you can have a small DWI and have no mismatch, but those people are actually quite functional. They don't have a major deficit. They're not hemiparetic. They're not aphasic. They're fully compensated. So if they're symptomatic and you have a small DWI abnormality and you have an occlusion, you have 100% of the time, I've never seen an exception, a huge mismatch, period. So why measure it? There's no point. It doesn't add any value, no additional information.
Sure. And so a couple more device questions. Do you predict similar results, or what do you expect to see with aspiration thrombectomy trials? And also, in terms of the new stent reaver devices, have you seen any issues with reintervention, or are reintervention rates lower?
Yeah, we don't have enough data on that. I mean, the aspiration devices, we do use the aspiration devices, and basically some of our interventionalists start with aspiration, and if it works, they're done. If not, then they move on to stent retrievers. It's sort of a two-step process because it's so fast. When it works, it's just so fast. The other, there's not enough data that I know of, that I'm aware of, to answer the other questions. It's still early days for the stent retrievers. I mean, it only came on the market or came on board just 4 or 5 years ago, which is not a huge amount of time. And these trials are only, well, they just got published, but they're only a couple of years old. So this is really new times. These are early days of these great devices. So we'll need to wait and see, and wait more studies.
All right. So I think we're going to call it there. Thank you so much, Dr. Gonzalez. It was a great talk. I want to give a quick plug to a couple upcoming talks. On September 21st, we're going to have another talk on stroke neurointervention, and we're also going to have a VDSL Angio Club on complex lower extremity interventions on September 23rd. Submissions are due September 6th. Thank you so much, Dr. Gonzalez. You probably can't see this, but in a lot of the questions we're getting thank you, really great, excellent talk. So I just wanted to, we're getting a lot of questions that are just thank yous.
Well, it's been a real pleasure. I've enjoyed it very much.
All right. Thanks a lot, everybody. Have a good night.
Bye-bye.